Hi, I'm Sean Churchill, an orthopedic surgeon in southeast Wisconsin with Aurora Advanced Healthcare. Today we're going to talk about shoulder arthritis. In particular, arthritis is the destruction of a joint. The cartilage surface ultimately wears away and you get bone-on-bone contact. That's what arthritis is. Ordinarily it happens in weight-bearing joints, such as your hip and knee, even your ankle, but it can also occur in non-weight-bearing joints, such as your shoulder and elbow. Shoulders are my specialty, so today we're going to talk about shoulder arthritis. Now, shoulder arthritis can present in many ways. Usually patients have discomfort or pain at night. Oftentimes they have a difficult time sleeping. They frequently take over-the-counter medications such as Aleve, Advil, Motrin, that type of anti-inflammatory to help relieve the discomfort. When that doesn't solve the problem, frequently then they see a physician. One of the things that patients notice with shoulder arthritis, in addition to the discomfort and ache at night, is a limitation in motion. Because you no longer have a smooth joint surface and you have the bones rubbing against each other, that joint surface is irregular and ultimately leads to a reduction in motion. It's reduced not only because of the pain that the patient feels, but also because the bones are rubbing against each other and can form bone spurs. These bone spurs are called osteoarthritis or osteophytes off of the osteoarthritis. Those bone spurs can limit motion, and when that motion starts being limited and their shoulder starts scarring in, they get frustrated. Simple activities such as taking care of themselves, bathing, hanging up a coat hanger, putting on a jacket, fastening a seatbelt in your car, all these can become very difficult because you've lost your motion. Ordinarily, it's not only motion over your head, but motion up your back, out to the side. Ordinary things such as passing a belt become a chore. That is when patients usually see a physician. Now, what are the treatments for shoulder arthritis? Well, there's several options. In addition to regular over-the-counter anti-inflammatories, we could try prescription anti-inflammatories. There's numerous anti-inflammatories on the market, some of which are cleared by the liver, some of which are cleared by the kidney, so we take a look at the patient's medical profile and decide which one to proceed with first. Even with one of those fails, we can try another alternative because there's so many on the market and each patient responds differently. If that doesn't work, occasionally we'll start some physical therapy to try and maximize the range of motion that the patient has. But ultimately, that is limited by the bone spurs or the osteophytes, which are present with their osteoarthritis. If that doesn't work, occasionally we'll try a cortisone injection to try and reduce the inflammation in the joint and make it a little bit more comfortable. When patients get to the point that their quality of life is limited, they're not sleeping appropriately, and we've tried the conservative measures and they still are struggling, that's when we would consider shoulder surgery for this. One of the things we do to prepare for that is we get a good set of x-rays of the joint to see how much arthritis there is in the joint, and then surgical planning can take from there. If patients need an MRI, if we're at all concerned about the rotator cuff, we would go ahead and order that study, but it's not routinely done for shoulder replacement surgery. During our last segment, we discussed what shoulder arthritis was and what some of the conservative or non-operative treatment methods really were. Now we're going to talk about the actual procedure. The surgical procedure involves replacing the arthritic ball on the end of the humerus with a metal ball and replacing the socket with a Teflon-style plastic liner. Together with those, you have a nice smooth joint following that, and also the scar tissue is removed so that your range of motion improves. Now I've got a model here, and this model is the end of the humerus. This is the upper end of the bone here, and what we've done in this model is we've actually removed the arthritic head. And now that arthritic ball has been removed off, and as part of the surgery then we prepare the canal on the inside here to take an implant. Now the actual implant is a stem that goes down the inside of the bone and then a ball that covers it. The actual implant is shown right here. These come in two parts. There's about 8 different parts here for the stem that goes down inside the bone. This is press fit and actually stays in with the body growing around it. For the actual ball, there's about 40 different styles and sizes of ball, so we can mix and match to pick the one that's just right for each patient. After that is completed, this side of the procedure is complete. Then we release the scar tissue to make sure that after the entire procedure is performed, the patient has optimal range of motion. The next procedure is working on the socket. Now the socket is actually the scapula or the glenoid bone. And what this is a small little socket, almost like a golf tee, doesn't have much space there. And we frequently will clean it off from all the arthritis and the bone spurs, and then we'll prepare the canal to go ahead and accept the liner. And this liner is cemented in place. There are several different styles of liner. The liner that I use has cement on the outside, and then the inside allows bone to incorporate and grow around it for longer lasting life. Once this is held in place, now you have a nice smooth joint surface there for the socket. And together it makes a nice smooth socket here. You can see here the ball and socket would then move together smoothly like this. And again, the scar tissue has to be removed at the same time, or else your motion would be only marginally improved. But together, by releasing the scar tissue and replacing the joints, you can have a full range of motion. After surgery, what's normally done is the patient goes to the recovery room and spends several hours in the recovery room. Then they'll go to the regular nursing floor, and I have my patients wear a sling for 1 day. After that day, I see them in the hospital, I remove their dressing and I change it to a much smaller dressing, and the therapy starts immediately. The therapy involves a stretching program working with the arm above the head and out to the side. Frequently, much more motion is obtained on the day after surgery than they had for years before surgery. They'll start a stretching program which they complete on their own for about 2 weeks. At 2 weeks, they'll come back to my office, we'll remove the stitch, and then we'll start them involved with more advanced therapy. For the first 6 weeks, we just work on range of motion, trying to maximize as much of the motion as we can get. And then starting at 6 weeks, we start a strengthening program. My only limitations for this for the long term are no impact activities, such as chopping wood and sledgehammer activities. Other than that, patients can swim, golf, play tennis, or do all the other activities they like to do. Shoulder replacement isn't for everyone, but for patients who have their quality of life limited due to osteoarthritis, it can sure improve their quality and allow them to do many of the daily activities that they could not do before. Thank you for listening. I hope you learned something from this. And again, this is Churchill working with Aurora Advanced Healthcare in the Department of Orthopedic Surgery.